This is just an introduction to my Facebook page and YouTube channel. Now today we are going to discuss aspirin, a wonder drug in prevention of cardiovascular events. Actually, in recent few years we got some studies which have created some doubts about its use in primary prevention. No doubt that aspirin is part and parcel of secondary prevention, and it should be given religiously to every patient, and we believe that it prevents events, especially atherothrombotic event. So what I'll do, I'll set a stage for discussion and the expert comments regarding the present state of use of aspirin in primary prevention. Should anyone need aspirin for prevention of coronary artery disease, and why? That we'll discuss. And in this presentation, we'll go through rationale of using antiplatelets, why we are using it, assessment of cardiovascular disease and bleeding risk, a very key point when you are trying to give aspirin in primary prevention. Looking at the present evidence, and lastly, who to receive aspirin in primary prevention, especially in our setup. We all know that vascular disease is a generalized process which is progressive. And usually we encounter our patient once we have this event after rupture of plaque. Now, in a number of patients to whom we are considering primary prevention, we actually don't know whether this patient is harboring disease or not. Because this patient, once if he's having a plaque which is 20, 30, 40, even 60%, he's not going to have symptoms. And we are creating different modalities to pick the risk of patient. And that is the main decision maker whether we should be using aspirin or not in this particular patient. That's very important to understand. Cardiovascular disease can't be picked as such whether your patient is having plaque or not. That's very important. So it means the disease has two phases. Atherosclerosis, which is a initiation and progression of a plaque, a silent disease. Nobody knows who is having that. We are trying to create modalities to pick it, but still we are not confirmed in our patient who's having athero. We always get our patient once our patient have this second phase of the disease, which is thrombus formation and leading to event. The same patient just one day before is considered as primary prevention, although having disease, but next day when he had event, we consider it secondary prevention. Just on the basis of event. That we all know, that for the basic stuffs for our junior, that how this platelet cascade play a major role in this event, and even the consequence of event. Sometimes your aspirin doesn't prevent, but at least take care of the severity of the event if it's on board in your patient. And we all know that it's not just the heart. You can have these events at every vascular bed, leading to different consequences. That we all know how aspirin acts and take care of this cascade. Prevention misconception. Can we prevent IHD with aspirin? No. We can't prevent IHD with aspirin. What we do, we can't prevent, which is atherosclerosis, but can reduce atherothrombotic events with aspirin. That's the key. We're using aspirin not for taking care of atherosclerotic plaque. It's for those events which are on superimposed and leading to different consequences. Now when we consider it for primary prevention, we have to integrate benefits and harms. And how to do that? Benefit of aspirins are related to underlying risk of CV events, and harms are independent of CV events. And when we really weigh according to the patient risk, if your risk is high, even in primary prevention, it's more beneficial, irrespective of its harms. And that's the key to understand how to weigh your patient, how much risk is he having of cardiovascular event, and then decide about aspirin use. In high CVD risk population, benefit exceeds harm. In low to medium, and that's the present evidence suggesting, in low to medium risk population, harms exceeds benefits. That's why this notion came that we don't have to give it in primary prevention. Now, even in primary prevention, you have to assess risk of your patients. It's not just the case, because we know the disease doesn't mean that your patient have no event. He doesn't have atherosclerosis. We don't know. And we are picking this atherosclerosis by means of risk assessment of our patient. And you see, most of these risk calculators are based on Western data. We don't know our patients, where even 20 years of young male are getting MIs now. Now it's a big chunk of patient between 20 to 40 are coming with ST elevation. Your age is so that वहाँ तो 40 को तो वो किसी calculation में डालते ही नहीं है 40 age को. So that we need to understand whether our patient needs aspirin or not. What constitute low, medium and high risk? ये जितने भी आप देखेंगे ये pool code, equation, age कहाँ पे इन्होंने डाली हुई है, less greater than 70 को risk बनाते हैं, और हमारे यहाँ जहाँ 20-30 साल के लोगों को MIs हो रहे हैं. इस ACVD में भी जो variable है उसमें age plays a very major role. Sex, age, race, total cholesterol, HDL. And on the basis of these risk calculator, right now, even in spite of those recent evidences, greater than 20% should be given aspirin. 7.5 to 20 depends on your patient interaction regarding pros and cons, side effects and everything. If your patient wants, you have to give aspirin. Low to medium risk, yes, you can avoid aspirin. But still now, you have a lot of variables to see in your patient, and still they are not enough to finally decide regarding your patient risk. We're using a lot of things, calcium scoring, CRP, family history, ABI, others, conventional risk factors, these scorings. In spite of all that, you can't really decide whether your patient is really at heart. Now, how do we use these findings? Low risk, don't offer aspirin. Medium to high risk, discuss the pros and cons with patients. Very high risk, recommend aspirin. And that we are talking about primary prevention. In secondary prevention, we have to give aspirin. The new evidences which have created some doubts or reservation of using Aspirin, Arrive and Ascend. Aspirin, healthy old age individuals. So you pick different group of patients with selective risk factors, just old age. As Arrive, middle-aged, non-diabetics. Ascend, young diabetics. But our patient most of the time are combination of multiple things, even at young ages. So I don't know whether we can apply this whole data to our population or not. We don't have answer unless until we have our own studies in terms of patient risk and their future analysis regarding events. That is just a different Arrive, multi-center, double-blind, low-dose aspirin. And dose they most of the time have used in all these trials 100 milligram. Although we can use 75 to 81, which really reduces the risk of bleedings. Even in Ascend 100 milligrams. Again, coming back to after discussing all these points to create regarding their expert comment, just how to really judge whether your patient is at this stage or not. That's the key to judge for deciding whether your patient need aspirin or not. His risk of having atherosclerosis, so that he should be on aspirin to prevent atherothrombosis events. So primary versus secondary prevention. Does just one event made your patient eligible for aspirin, and just one day before he is not eligible for aspirin? That's the key thing to understand. Just coming to the conclusion so that we can move on to the expert comments about this whole subject. Present evidence created controversy about use of aspirin in primary prevention. But should that evidence be applied to low and intermediate risk, or every patient irrespective of risk? That's the key question when we are suggesting or trying to contemplate whether our patient need aspirin or not. Thank you for your patience. I think we can move on to our experts. Any questions here?